I want to welcome everyone to our fourth session of our Telehealth Echo project. This session particularly is on telehealth for preventive care, everything that you need to, all the considerations that need to be taken into account when you are conducting a telehealth visit and you are providing preventive care. I ask you to please put your name in the chat box. That way we can have an accurate count for CME purposes. The entire series is 6 lectures, and we've had already the first 3. We are on the 4th session today. There will be 2 more, one in March 18th on social and cultural considerations, and April 1st on telehealth after COVID. If you look on the right, the pie chart that actually shows the structure of our echo sessions, which are basically welcome and introductions. We tend to skip that a little bit because we don't want to get into, we don't want to take time from the actual didactic session. When we have comments on the second portion of the hour, you can introduce yourself and tell us your concerns, your questions, your comments by introducing yourself and telling us what practice you represent. But once we begin with the didactic session, we'll have about 25 minutes of that. And then after that, we have Dr. Valencia will be presenting a case. Cases may or may not be relevant to the preventive care. In this case, they are, but they don't always have to be. And when we do the case presentation, then we'll have a Q&A and a more interactive session. So today we have 2 speakers. The first one is going to be Natasha Doshi from the CMA. She's a practice transformation specialist. And the second speaker is Ginia Fick. She's the Vice President of Quality for IEHP. Both of them will be presenting telehealth preventive care considerations. Natasha on the more general aspect, and Ginia on the considerations for IEHP providers. And just a little commercial, we still have 2 sessions. We need interesting cases. If you would like to provide a case for us, we would appreciate it. Just communicate back with me. You can reply to any of the emails you get from me, and then we'll guide you to get to the Google form where you can document your case. So this is telehealth for preventive care. And this is Natasha Doshi. Natasha has extensive knowledge working in the public health sector among healthcare organizations in Los Angeles County. She has deep experience in providing consulting services and technical assistance for federal qualified health centers, the FQHCs, as well as implementing various practice transformation projects within the safety net population. Over the last year, Natasha's work has focused around the large-scale HRSA-funded Health Center Control Network program, a health IT-focused initiative with 45 health centers in Los Angeles to optimize electronic health record technology, health information exchange systems, and adopt long-term telehealth solutions to promote virtual care. Please welcome Natasha Doshi.
All right, so thank you so much for that introduction, and thank you to everyone to allow me to be a part of your meeting today. I'll be providing some information on using telehealth for preventive care purposes. So to provide some background, preventive care in 2020 drastically declined, right? And I'm sure you're all aware, and many services, especially childhood vaccinations, declined significantly over the course of the last year. So this chart here from the New York Times outlines that in about mid-April to May, vaccines declined as much as 75 to 80% and are slowly coming back up to a normal rate. But we're seeing that a lot of our health centers are, having to play a bit of catch up. I know one of my health centers is talking about potentially opening up hours on Saturday just to catch up on those immunizations. So while vaccines and other childhood immunizations need to be done in person for the most part, there are still many ways that telehealth can play a part in preventive care at your practice. So today I'll be addressing 4 main areas: outreach and scheduling, virtual screenings and assessments, follow-up and counseling, and last but not least, I'll talk a little bit about what a hybrid visit model can look like. Okay, so for the first thing that I usually recommend to my health centers is to establish a criteria for telehealth visits and then identify which patients on the schedule fall under each visit type. So I have one health center that only utilizes 4 different visit types for documentation purposes. Pediatric visits may be scheduled differently in order to conduct those well child exams or parts of it at the health center. So, of course, our main priority is to consider safety and patient preferences always. I really do believe in a shared decision-making model, so patients and clinicians both feel a sense of autonomy in their schedule, and they have some say over the type of care that they're either giving or receiving. Okay, so these are some examples of telehealth versus in-person services that we use in the FQ setting. I won't go through all of these, but I do want to emphasize that really any follow-up, consultation, health management discussion, or completing health assessments or like health questionnaire forms can be done through a telehealth visit for the most part. And as you can see, like some of the more, some of the services that require in-person services are to be expected, right? Immunizations, lab tests, any clinically urgent or serious medical emergencies. Obviously, we know that we want to address those right away. Shouldn't be scheduled in a telehealth visit. Okay. So for the patients that are due for in-person services, like immunizations, wild child exams, routine labs, or screenings, outreach should be conducted to these patients to schedule an appointment within the office. I think just right off the bat, over-explaining this helps a lot in providing patients reassurance that health and safety protocols are in place so that patients can visit the health center safely. It's also worth noting in determining if parts of the visit can be done over the phone or through video, such as new patient intake questionnaires, health assessments, and lastly, follow-up consultations and health education appointments can be conducted through telehealth visits, and we'll provide some examples on that in some later slides. Okay, so these are some example messages or scripts that scheduling staff can use based on what we talked about. The following slide also has some examples on responses, but really the first message here is geared towards an in-person visit, just kind of outlining that the health center has implemented precautions, safety protocols, so that the patient feels safe coming into the clinic, especially as COVID cases decline. Obviously, we're going to see a little bit more of that. And then the last 2 messages are really geared towards scheduling telehealth visits, noting that obviously it's centered around patient preference. If they're interested in moving forward with scheduling a telehealth visit, then, that consent will be documented as well. And so then these are just some example responses that you can also provide to scheduling staff when talking to patients. So the first one, again, geared towards seeing a patient in person. The next 2 geared towards telehealth visits, either confirming what the patient's phone number is, or, telling the patient that they'll receive instructions to prepare for their visit, and this is where they can go to for that link. Okay, so I've provided an example telehealth outreach and scheduling workflow. And I apologize, the font is a little small, but I do think it's important and helpful to see how and when schedules should be reviewed based on clinical decision and patient consent. So, whether your scheduling staff is discussing these options with patients first, or providers are doing that directly with patients, is really up to your health center. Obviously, I do feel like clinical decision needs to be incorporated into determining moving forward who is totally eligible for a telehealth visit, and who would be better off receiving that care in person. And then when you do move forward with scheduling in person, obviously you always want to screen for COVID-19 symptoms and kind of just keep that practice in mind moving forward into this year. Okay, so a major component of preventative care visits are screenings and assessments, which have a huge potential to be conducted through a telehealth visit. So some of these screenings can include alcohol, tobacco, drug use assessments for adolescent populations, the PHQ-9 screening. I'm not sure if you all use the Staying Healthy assessment form, but parts of that can be conducted. Same as Bright Futures guidelines, right? There are components of that that can be conducted through a telehealth visit. And then, focusing on social determinants of health is also another thing to keep in mind. There are plenty of templates that you can integrate into the EHR. I know the Prepare tool is kind of like the catch-all long SDOH screening tool that does have the ability to be integrated into the EHR, and you can pull that up during a visit. And then last but not least, for trauma-informed care, as you look to implementing ACEs, maybe you already are using that in your practice, there's potential for certain sensitive screenings to be conducted in a certain manner over telehealth visits, and that's what we'll go into on the next slide. Okay, so these are just some tips for conducting virtual screenings. I think it's helpful to ask the patient if they're in a private, quiet location where they can answer some personal questions. Telling the patient that you'll be conducting a routine screening to gain a better understanding of their health, to just kind of give the patient context. I also think it's important to let the patient know that you ask every patient these questions. We want to make sure that the patients don't feel like they're in trouble or that they're being singled out, right? It's a routine screening. And then if the patient has headphones, you can also recommend that the patient wear headphones during the visit if they don't want screening questions to be overheard, especially if they live with others. And then on the flip side of that, patients can also give one-word answers that don't necessarily reveal the nature of the conversation. And then, of course, definitely provide patients with explanations or examples to questions that they don't understand. Document all responses in the patient chart for easy follow-up, and then connect patients to necessary departments for further care. Obviously, as a best practice, we want to also note if the patient declined to respond to the screening in the patient chart. And then lastly, and this is kind of just a best practice when you're doing any telehealth visit, not necessarily a screening, but let the patient know if you need a moment to document or if there's going to be a brief moment of silence. I think it's helpful for patients to know that it's not like you aren't paying attention. You're very much attentive. You just need to look away and document for a quick second. Okay, so inevitably, while you do these screenings or initial assessments, you might, as a follow-up, need to conduct a virtual warm handoff. So let's say you want to hand off your patient to your behavioral health team. So you can alert that person you're handing off the patient to via EHR alerts, phone calls work, text messaging, if you guys use a messaging platform in your health center. If you can transfer the call rather than having the patient hang up and then start a new visit, that's always ideal. I also think it's important to remind the patient to stay by the phone if someone else is going to call them to follow up. And then if not, you can also have the MA or scheduling staff follow up with the patient to schedule the visit for another time. obviously keeping documentation in mind, we want to make sure that, as a provider, you're documenting the patient's conditions, just any information you can give to make that handoff more smooth, just like an in-person visit. Okay, so with conducting a physical exam, some physicians may opt to provide annual checkups through telehealth. A lot of my health centers, personally, I haven't seen this being done as like a regular practice, but is another solution to look to in the future. But average to low risk patients may be good candidates for these video physical exams. And then on the screen, there are some guidelines from the AAFP telehealth toolkit that kind of go through what to look out for, what are some video cues. And then on the next slide, you'll see another checklist. So this is a 10-step checklist for the patient-assisted virtual physical exam provided by the American Journal of Medicine. As you can see here, some components of this visit do require that the patients have certain devices at home, like blood pressure cuffs, scales, thermometers, pulse oximeters. Obviously work with what you have. If you guys aren't using remote patient monitoring devices, you can opt to conduct those parts in person. Other components definitely rely on video cues and those observations. And if needed, you can have the patient also take close-up pictures, like as in a skin assessment. Okay, so with counseling and follow-up, I cannot stress how important it is to incorporate other members of the care team as needed, depending on the patient's health condition or results of the assessment. Counseling and follow-up through telehealth also provide more opportunity to provide education, right, on important measures like diabetes and hypertension. It also allows an opportunity to address certain HEDIS measures that you need to catch up on to achieve those performance goals. And then, I always think it's important to utilize motivational interviewing techniques and kind of listen and respond to the patient with empathy during telehealth visits to make that connection as close to an in-person visit as possible. Okay, so I'm going to quickly highlight some of the work currently being done at FQHCs for preventive care. There are a few health centers in our network that are using health educators and care coordinators to meet with patients through telehealth to discuss food insecurity, available programs, enrolling in SNAP, and they also might opt to administer a hunger vital signs screening to assess the patient's risk level for food insecurity. If you haven't used the hunger vital signs before, it's a really short 2-3 question screening tool that can be really key in capturing risk level. Food insecurity has also been on the rise in the last year, so I think it is important to incorporate ways to address this. And then I also wanted to highlight another clinic with diabetes management programs where a provider diabetes champion and an MA will typically meet with patients virtually to discuss self-management goals, how to check your blood glucose levels if they do have at-home kids, setting other nutrition and exercise goals. And then I believe that for this program, some patients did have low-tech blood glucose monitors that were either loaned to them or they had this type of device already. But for accuracy purposes, I know that a couple of health centers are still having their diabetic patients come in on a quarterly basis to get those A1C labs in. Okay, so moving on to hybrid visits. This type of visit obviously combines in-person and telehealth services. One of my health centers is using this for well-child exams, and they've actually had really great success with conducting what they can over phone and then bringing the patient into one specific clinic site. Other ways to implement this hybrid model may include designating a telehealth site or even a telehealth room within the clinic where patients can be assisted using telehealth technology at the clinic with an MA or care coordinator, and the provider might be at another site or working from home that day. This is just another way to address access and patient technology limitations. this is a huge problem in the safety net population. We have a lot of patients who don't even have reliable cell phones. So bringing those patients into the clinic, I feel, is a long-term solution to help get those patients to have more access to their appointments. Okay, so this next slide just goes over a really rough workflow that I think is foundational of what a hybrid visit can look like with conducting telehealth and in-person pieces of the visit. So this includes, the point of care from patients requesting an appointment to the provider and MA potentially conducting the visit, determining if services need to be provided in person, and conducting routine follow-up as well. So on one last note, in terms of reimbursement, right, all services are covered and the temporary flexibilities under the expanded waiver are still in effect right now. So audio and video are still reimbursed at the same rate. However, it's important to know that I think at the end of February, DHCS did release a telehealth proposal that may be in effect around the summer of this year. The good news is that this proposal permanently expands telehealth payment parity for synchronous modalities. But the downside to this is that there will likely be lower fee schedule.
Can you please explain that a little bit? What is meant by
the synchronous?
Uh-huh.
So this would be video visits, real-time visits. Yeah. And yes, this does apply, or the DHCS proposal at this time does not apply to commercial insurance plans. I would definitely, look up specific commercial plans. This is for Medi-Cal in particular. Kind of something that's being debated right now is what the fee schedule is going to look like for reimbursement for telephone visits, asynchronous telehealth, which is like store and forward, taking a picture, sending it to the clinic, and then looking at it that way, and then remote patient monitoring. So these are currently in debate right now with the current budget proposal. So we still don't know for sure. It's something to keep in mind. I know that I'll be working with a lot of my health centers on kind of increasing and promoting the use of video visits because it is going to be very important moving forward if this is enacted. And lastly, I've just included some CMA resources that you can find on our website. And then on the next slides, you'll see some more coding and billing resources. And on the next slide, there's some workflow resources to adapting in-person, physical exams, annual wellness visits, conducting sensitive screenings over a virtual care setting.
And if you, thank you so much for this wonderful presentation, Natasha. If you, for all attendees, you can unmute yourself. You can also turn your cameras on. We'd love to see you. And any questions?
The hybrid
model,
this is
Tim watching.
The hybrid model looks like is a doable thing to see more number of patients compared to relying on either modality alone, like in person or the video calls. I think that is more a doable thing so we can provide care for more patients.
Yeah, absolutely. And I think that a lot of, like I said, patients within the safety net population who have benefited so much from this increase of access, they don't need to leave their home or drive anywhere to go to their visit. We obviously might see less at-home visits, but I think it still is nice to open up schedules and have that designated site where patients are also available to come in and to conduct that visit with the help of an MA, for example.
One other question I have is, you said the Department of Healthcare Services, their recommendation is to make a different payment for telephone versus video. So is that the same kind of position that CMA has, or CMA promoting a different modality?
So we aren't necessarily taking a a stance on what should be promoted. I do generally want to say that CMA, in terms of advocacy purposes, does want to promote equal, I don't want to say equal reimbursement, but wants to allow providers to be able to conduct those video and telephonic visits, especially if there are patient limitations, because more often than not, it's on the patient's end where there are those limitations in doing a video visit. Mm-hmm. I don't want to provide an official stance, but I would say, myself and the CMA organization obviously wants to help patients and providers. And I personally feel that, reimbursement for those services is important just to prevent a loss in revenue.
In addition to the technical problems that the patient may have, internet connection and various other things, it is not necessary to have a video call for every complaint. There are certain situations wherein a video will definitely help, like somebody wants to show a skin condition and things like that. Mm-hmm. But for various other reasons, various other complaints, we really don't need a video call. We can manage them on the telephone. But you are spending time listening to them and, then advising them what to do. So we spend so much time on the telephone also and provide mm-hmm. them useful information and manage the patient's condition. It doesn't need to be video call every time. So just my comment, that's all.
Yeah, absolutely.
I have a question. This is Lilia Copa. I'm in Oxnard. As far as vital signs, I always find the challenge, even just to get a temperature and a weight, which mm-hmm. should be, every family should have a thermometer and every family should have a scale, but it's been really challenging. I know that there are kits for vital, measuring vitals out there for sale, mm-hmm. but of course the financial limitations in each family may limit their ability to get something like that. In mm-hmm. the future, if telehealth is going to be here to stay, what kind of recommendations should we start preparing our patients with as they sign our telehealth consent to basically say, you need to avail yourself with a thermometer or a scale, a way to measure the child, especially for well visits where the growth and the weight of the patient is so important to document.
Yeah, and that's such a great point. I think that a lot of patients in the future will need to be loaned certain devices that they could use during that remote visit. There's also opportunity, depending on the patient's health insurance, there is opportunity where the health plan might provide certain devices. That really does depend on their insurance plan. And I know I think for diabetic patients, certain health plans also might provide blood pressure cuffs for those higher risk patients. So it is worth looking to what can be provided by the health plan first, and then following up, making an internal decision. Do we need to invest in certain resources to loan to our patients for these visits, annual or not? But that's the route that I would take as well.
Thank you.
Dr. Watson was asking if we can share the presentation slides.
Yes, absolutely.
This is Tim Watson. Can I echo something Dr. Rajashekar brought up? These telemedicine visits may not be as detailed, but they take so much time, double even the time. And I think that there's always this sort of drive to the lowest price for everything when it comes to state reimbursements. And I think that this may not be as detailed for the patient, but the time constraint is insane. And the average family, I don't know if this happens with those of you who have kids, but I call my wife. My kids are now, 10, 12, 14. It is impossible for me to call her without one of them pawing at her with a question in the middle of my call. And this is very common with our patients when we call them. They have so many distractions in their house. The kid is right there crying in the ear of the phone. You can't hear them. And this dynamic actually just prolongs what should otherwise be very simple and straightforward. So if anything, I almost think telemedicine we should argue that it's paid at a higher rate because of the time constraint. And so, this sort of tendency to underpay because they don't think it's as detailed. I don't think payers understand the value of our time, which is sort of the never-ending quest of the doctor, recognizing that their time is getting eaten up on every side. There's constantly someone asking you to click one more thing, do one more tiny little thing until the straw breaks the camel's back. So anyway, that's my comment.
Absolutely. I totally agree. And I think that also, promotes and further advocates for use of other care team members in the visit to kind of save provider time and reduce so much burnout that was already an issue before. And I know it's something that needs to be addressed. So absolutely.
Natasha, thank you so much for your presentation. We need to move forward. And any other questions that may rise, you are all welcome to email them to me, and we'll convey them to Natasha to get you the answer. And we will be sharing the presentation as well. So we're gonna move on to our second speaker. Genia Fick has been a part of the Inland Empire Health Plan team for over 15 years and has spent much of that time working in the field of healthcare quality. Currently, Genia serves as the Vice President of Quality, where she is responsible for leading diverse teams that support IEHP's quality programs across the organization, including quality monitoring and oversight, quality improvement, NCQI accreditation, HEDIS reporting, healthcare analytics, provider quality audits, pay for performance and value-based payment programs, and more. In addition to her work at IEHP, Genia has over 7 years of experience serving as a certified HEDIS compliance auditor for the National Committee for Quality Assurance. Genia has a master's degree in health psychology from Northern Arizona University, where her studies focused in psychological links to health, research methods, and statistics. Please welcome Genia Fick.
Hi, thank you for having me. And I'm going to share my screen. So just give me one moment while I pull up my slides here. So I'm actually going to be providing an overview from a health plan perspective. I know many of you are serving in the Inland Empire and are familiar with IEHP's programs, but we're very supportive of this topic of really digging deeper into how telehealth can be leveraged in different ways, and definitely in the space of preventive care services. It's definitely an area that's new and growing, and we're definitely excited to support further learning of how we can do this even more. And so just to start off with sharing a little bit of our data and our kind of trends that we're seeing so far. We're seeing, downward trends as well for 2020 in our, preventive care services for our pediatric populations here at IEHP. We're seeing some pretty significant declines in the well care visits for our adolescents and for our 3 to 6 year olds. And we've been working really hard with our primary care network to improve our childhood immunization rate. And while the rate is still pretty low, we are seeing positive trends even in the COVID kind of time period, which is encouraging. But recognizing that this has really been an area of decline, and definitely something we want to continue to work on solutions, including how to leverage telehealth to help close some of the gaps in preventive care services. We are seeing, just by looking at kind of the encounter data that is coming in from all of our primary care offices across San Bernardino and Riverside counties, that we are seeing an uptick in the telehealth visits. And so we are encouraged by this. So we are seeing more and more use. We are really asking our primary care providers to really stay diligent in ways to keep our up to date on those key preventive care services. And so we do want to really push that telehealth mode wherever possible. As Natasha mentioned in her presentation, DHCS has expanded, and we at IEHP also have expanded our billing allowances for telehealth. And so there's that parity of services right now, and we are hoping to continue that moving forward into the future as well. Our priority remains really unchanged. Timely immunizations and timely well care visits is a really key focus at IEHP in our quality improvement journey. And we really have started to provide more specific billing guidance and capture services that are being conducted through telehealth. And then really thinking about even ways of leveraging that patient reported in some of the visits. Looking at telehealth a little bit deeper, we of course are continuing to receive those preventive health services that are consistent with the Bright Futures guidelines and timeframes. And we want to always remain aligned with really what's the latest recommendations out there for leveraging telehealth, and also with everything related to the pandemic. So we recognize that there are scenarios where the telehealth option may be, a one way to accommodate, whether it's improved access to care on a normal kind of year, or being safe during a time of a pandemic like what we're currently experiencing. We recognize that hybrid model may really be a really powerful way to keep our children on schedule with these Bright Future visits. So of course, immunizations are really important for our infants and babies under the age of 2, with many shots that are due at different periodicities in their first 2 years. And so those of course need to be continued to be offered in the office. And that is really still something that we really want to encourage and not fall behind on. But when we start looking at the older age groups, so over the ages of 2, we really see opportunities opening up where the telehealth visit may be one way to approach these well care visits. Again, it's ultimately up to the physician to determine clinical appropriateness of a patient and whether or not their risk level is appropriate for a telehealth visit versus an in-person visit. But we really do want to encourage our providers to really bill for all the components that they are offering so that they can maximize their earnings in quality programs, as well as some of the programs that are still out there from the DHCS program perspective, which I'll cover in a little bit more detail in a minute. But what's really key here is that billing documentation, coding all of the components that are administered during a telehealth visit so that you can really maximize those earnings. We do have some modifiers in place of service codes that can be leveraged to help you designate that the visits are being conducted through telehealth. And of course, when visits are happening in person, coding all of the components are continue to be really important so that you can maximize your quality earnings on some of these quality improvement kind of specific initiatives. Similar to the prior presentation, there are some components that could be maybe more easily administered through the telehealth mode, and others where it's just really not practical at all. And so this slide here is just giving some examples of some of the components that could be administered through a telehealth visit, including a visual physical exam, the physical development, health education and anticipatory guidance, nutritional counseling, BMI assessment, and of course, if they have a scale and are able to measure their height, the ACEs screenings, as mentioned on the last presentation, health history, mental development, those assessments, the state assessments, a staying healthy assessment, and the IHEBA. Counseling for exercise and developmental screenings are all components that can be done through the telehealth mode and not required to be done in person. Of course, the physical exams, any in-office testing, including the fluoride varnish, which is a new kind of area that's really being promoted by DHCS with our primary care providers, and of course, immunizations all need to be done in person. Looking at sort of how you then turn a virtual visit into, but really to any health plan, because these are all standard coding practices, would be to call out your individual components that are being assessed during a virtual visit. And then what's really key here is including either the modifier 95, which is one way that you can sort of set up all of your telehealth visits to capture that mode through the modifier 95, or you could use a places service code 02. And either of those are considered acceptable ways of noting that the visit component was done through telehealth. This slide here provides some examples of programs at IHP where if you do designate kind of those individual components in your billing practice, you would be able to receive additional incentives through our Global Quality P4P program. So an example would be, we do encourage providers WellCare visit rates. And so by completing many of those virtual visit components and using a CPT code to designate that a WellCare visit with your modifier 95 or with your place of service at 02 would capture that well child visit at IEHP, and that would qualify the provider to receive that incentive. Also, for individual components like the nutrition counseling or the exercise counseling with specific ICD-10 codes, that would allow for credit towards specific measures in our P4P program. Same with the BMI assessment. And then the last two at the bottom are the ACEs screenings and the developmental screenings, which are part of the DHCS Prop 56 programs, where there are incentives for those services in particular. And by noting just that modifier or place of service through telehealth mode is captured, it would still be eligible to receive payment. So I think that the main message here, this is a nice reference sheet, but really, thinking about all the different components that you do offer through that telehealth visit really could be captured as an individual sort of billable code that could result in additional payments on top of your normal capitation or your normal payments. So these are really add-on bonuses that are available and that really align nicely with telehealth visits. So I just sort of highlighted these three because these are kind of, a really sort of like a missed opportunity area that we see, at least in our provider kind of network, where we may see visits being billed through telehealth, but maybe not documenting kind of those individual components as thoroughly as they could. And so they miss out on opportunities for that additional payment. So just wanted to highlight those as a really great ways that you could capture it through those ICD-10 codes. Again, we really do encourage that you think through how that in-person component could be completed within a reasonable time frame after a telehealth visit may be conducted. And so we do ask our providers to, build that into their follow-up plan to come in and get those in-person components completed timely. And again, we would encourage then for those individual components to be documented in their billing to the plan, along with their place of service office, which is place of service 11, so that they can continue to receive credit towards any of the other programs and specific offerings. So this again is a nice reference slide just to show that there are codes in particular that would allow a provider to bill both the virtual visit and then that follow-up in-person visit at a later date. There also has been some flexibilities really nationally around quality measurement and kind of billing around patient-reported biometric values. And IEHP is very much wanting to remain aligned with the national sort of measure designations and guidances. And so in 2020, there were some relaxed rules around patient-reported biometric values like height and weight, for example, would be a really great way that you could still assess the members or patient's BMI percentile with that patient-reported information. And then what's really key here is that you document that in the members' health record, and with, of course, the date that that visit was recorded and the information was recorded. Global BMS event. So I think that is my last slide. So I'll pause to see if there are any questions.
I have a question. This is Tim Watson. Thanks, by the way. That's a great presentation on sort of the future of this. And I appreciate you and your team advocating for our patients and the doctor's survival in this process. So my question has to do with billing when you have multiple visits about the same thing in an under 7-day period of time. Now, I know that with some resources that actually, sorry, lunch arrived. So that actually is something I'm unclear on, but my understanding is if they come for problem A on day 1, and then that problem gets readdressed on on day 2 through 7, you can really only bill for day 1. Am I misunderstanding that?
Dr. Watson, that's actually something that I have not heard. The general guidance that we've heard, and I can follow up and get a little bit more clarification, is really every event could be documented as an encounter. So the initial visit on day 1, you would document, with all the components that were addressed. And then again, if it's on day 2, or day 4, whatever that next visit is, we really do encourage our providers to document and bill for really all of them individually. And we have not heard that would be in violation of any sort of billing rules. But I am certainly happy to kind of follow up and just see if I do find any other contradictory guidance on that subject.
It may be that this is a Medicare thing and I'm crossing my wires.
Could be. It could be.
Yeah. Mm-hmm. So I just want to make sure that,
for Medi-Cal,
we're doing it right.
Yeah, no, for Medi-Cal, I think what's really important is, the state's been very consistent and, message, really documenting all of the services that are happening out there in the offices, whether it's health or, face-to-face at this point.
Ginia, we can't hear you.
Hello?
You are breaking up.
Oh, okay, let me try to do something here. Is this any better?
Yes.
Mm-hmm.
Okay, apologize. The positioning for my EHP is, from the perspective is really to promote complete capture of services happening out there to the Medi-Cal berries. And so really documenting the services that are happening are really so Dr. Watson, it may be a Medicare rule that you're thinking about, because I haven't heard that 7-day rule mentioned in any of our guidance.
I'm going to take a last question because we're really running out of time. Mitzi Young asked if IEHP has telehealth toolkits for underserved patients.
That's a great question. Not that I am specifically familiar with. So at this time, we don't. But that's a great resource that we really should be looking to develop.
Yeah, they
I
do
don't have
have
any
some
at this
federal
time.
grants. There's some federal grants out there. I know that some of the, like Banyan Health, I think they're in Missouri, and Arkansas has some of these things where they're sending them these kinds of kits with, the scales, they even have an iPad or some kind of a
I
device
see.
that way. And so anyway, I just wondered if that was something, because we talked about that earlier in Natasha's presentation.
Yeah, so Mitzi, great question and clarifying that. So I think one thing I know that we are doing is with the blood pressure cuffs. Those are being offered to IHP members who have a pre-existing condition of hypertension. So we are starting to at least offer some of those devices, but looking at it more through the lens of like pediatric care. It'd be interesting to see what else might be available to help support members having what they need at home. So I think that's a great,
so I'll shoot it over to you.
Okay, well, thank you so much,
you.
Genia, for a fantastic presentation. Any more questions, we'll make sure to send them your way. And if both Genia and Natasha can hang on for a bit, we have a case presentation by Dr. Valencia. And towards the end of the case, the question within the case is specifically what are the correct billing codes to use. So I'm going to let you, Dr. Valencia, present your case.
Okay, hi to everybody. So basically, my questions were already answered by Natasha and Genia. So this is the hybrid visit, just like what they discussed. I have a 16-year-old male, African-American. We haven't seen him for more than a year. So, and he has Medicaid insurance. So he's basically also due for his 16-year-old adolescent visit. But the mom called basically just asking for refills on his acne medications. So I went over his records, and he does have other conditions that we need to address, like obesity, asthma, allergies. So I was really wanting to just get him in person for a adolescent visit, but unfortunately our first available appointment is not till 4 weeks down the road. So I decided to go ahead, make a telehealth visit with him, just to get just to see how he's doing, because we haven't seen him for over a year. So we did discuss his problems, including the acne. And since he was already in front of me, then I went ahead and did his asthma check, the ACT, the ACEs, and the PHQA. We're just starting to do the craft. So I didn't have the forms at that time. So basically what I had was what I did, and refilled his medications, and at the same time, made an in-person visit in 4 weeks, which is what is available for adolescent care and follow-up appointment. Now, I did bill 99214 for a 15-minute video interaction and a 60 minutes reviewing the previous charts from the night before. So I was just wondering if that's basically kind of the correct thing to do. Question for Genia and Natasha.
I see Genia did respond.
Hi. Yeah, I was responding to Dr. Copa's question earlier, but so I read the question here. So doctor, you used the 99214 code, and so you would want to also designate, either the modifier 95 or that place of service 02. So whichever one works, for your billing system, either one would work. So you'd want to make sure you include that. But you would also want to include, in addition to the 99214, those other codes that I had up on the screen that would reflect, the depression screening for sure, the ACEs, because those are separate pieces of that visit that are also billable, and it would help you earn additional dollars on those quality improvement programs with the state as well as with IEHP. So it looks like, yes, the 99214 is a good code to use, but you would want to also bill for that depression screen, which I think is on my slide here. It's 96110. You would also want to bill for, let's see, the ACEs. So there's 2 G codes you could choose from for that. You would want to talk about your the BMI assessment code. You would want to also capture any nutritional counseling or exercise counseling. If you did any of that, you'd want to capture those ICD-10 codes as well. So I would just enrich what you did with a little bit more detail, and then that would give you a better opportunity to earn kind of all the different ways, possible for that visit.
Okay, perfect. Yeah, I did all that.
Ginia, one question.
Yes.
This is Rajashekar. Dr. Valencia also did the partial well child care. When you do a partial well child care, don't you bill for the well child care?
No, you
Like
can't.
392 or 394, whatever the age group is.
You could, absolutely, yes. You could do that. I would say instead of the 99214. That is it in addition to or instead of? That's actually a little bit more beyond my billing understanding.
Okay.
So I think it would be one or the other. I believe would be the safe answer.
I have a question for Genia. This is Dr. Murthy. After this, Dr. Valencia in 4 weeks will see for well child care. So if she had used the 99394 for a well child visit, so the following in-person well child, how will we bill?
Yeah.
You would do the same code if it was, again, like sort of the continuation of the well child visit. And then this time you would note, of course, the place of service being in the office instead of telehealth.
We can use the same code, well child visit for.
Yeah.
Okay, good.
Yes.
Thank you.
Yes.
Okay. Oh, perfect. Okay.
Thank you, everyone. We had come to the end of our hour. Thank you for both of you for your presentations. If anybody has any more questions, please feel free to email the chapter. What I'm going to do is I'm going to email everyone, as I did this morning with what I'm going to do is I'm going to email the slide decks. Genia, are your slide decks okay to share with the group?
Yes, they're fine to share. Thank you.
Okay. I will convert both of them to a PDF document, and then I will share it with the group. Our next webinar is on March 18th on social and cultural considerations with telehealth. Thanks, everyone, for joining us today.